Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very handy in your line of duty. I now welcome you all to part 305 of our pharmacotherapy series, which majors in chronic stable angina. The first question relates to patient JAP in parts 303 and 304 of this pharmacotherapy series. Does isosorbide mononitrate offer any distinct advantages over other nitrate preparations for angina prophylaxis? Isosorbide mononitrate is the primary metabolite of isosorbide dinitrate. In fact, most of the clinical activity of isosorbide dinitrate is due to the mononitrate. Therefore, both drugs share a similar pharmacology. Isosorbide mononitrate does not undergo first-pass metabolism and has no active metabolites. Its oral bioavailability is almost 100%, and its overall elimination half-life is about 5 hours. Maximal serum concentrations are observed 30 to 60 minutes after a dose. To minimize the potential development of nitrate tolerance, isosorbide mononitrate should be used in a twice-daily, asymmetric dosing regimen in which the first dose is taken on awakening and the second dose about 7 hours later. Because of this unconventional dosing pattern and the availability of the extended-release product, which can be taken once a day, most use of isosorbide mononitrate is in the form of the extended-release preparation. Pharmacists must be sure to recognize the difference between these two products. General precautions and adverse reactions for isosorbide mononitrate are similar to those for the other nitrates. Potential advantages for the clinical use of isosorbide mononitrate are less dosage fluctuation because of the absence of presystemic clearance and an effective once-daily or twice-daily dosing schedule, which could perhaps lead to improved patient adherence. Nevertheless, isosorbide dinitrate is effective clinically when administered 2 or 3 times a day and is a viable alternative. The next question reads, JAP likes the idea of using topical nitrates instead of an oral agent. Are the transdermal patches a viable alternative? Transdermal nitroglycerin patches were originally designed to provide anti-ischemic protection with once-daily application. The concept of a compact, easy-to-apply transdermal nitroglycerin patch prompted pharmaceutical manufacturers to design a number of products, which the FDA subsequently approved based on plasma-level data, not clinical efficacy studies. Subsequently, the shortcomings of plasma-level data have become apparent and prompted numerous clinical efficacy studies. Transdermal nitroglycerin therapy has been shown to increase exercise duration and maintain an anti-ischemic effect for 12 hours after patch application. These beneficial responses remained consistent throughout 30 days of therapy. No significant nitrate tolerance or rebound was noted when the patch was applied for not more than 12 of 24 hours. Although the various patches use different pharmaceutical delivery systems, clear-cut advantages of one over another are not apparent. Despite variations in surface area and nitroglycerin content, the most important common denominator of the transdermal nitroglycerin systems is the amount of drug released per hour expressed as the release rate, e.g., 0.2 mg per hour. Each product label includes this information. Low dosages 0.2 to 0.4 mg per hour may not produce sufficient plasma and tissue concentrations to produce a clinically significant effect. However, it is still recommended to start with a low-dose patch and titrate upward as needed. Because the skin is the major factor influencing nitroglycerin absorption rate, product release characteristics do not favor one system over another. Contact dermatitis has been reported with the transdermal patches. Patient instructions are included with the patches and should be reviewed with the patient, emphasizing the appropriate time for application of the patch, removal of the patch, as well as the appropriate sites on the body where the patch should be placed. The next question reads, TBN, a 56-year-old man, has just undergone cardiac catheterization, which showed two-vessel coronary artery disease with obstructions of 55% and 65% in the right coronary and circumflex coronary arteries, respectively. Before catheterization he had a 2 to 3 month history of exertional angina for which his primary care physician prescribed sublingual nitroglycerin tablets 0.4 mg and oral isosorbide mononitrate 60 mg once daily. TBN discontinued the use of isosorbide mononitrate after a few weeks due to intolerable headaches. His medical history includes asthma, hypertension, and hyperlipidemia. Currently, his other medications include losartan 100 mg once daily, fluticasone inhaler 2 puffs twice daily, albuterol inhaler 2 puffs as needed, aspirin 81 mg daily, and atorvastatin 20 mg daily. Current vital signs include a resting heart rate of 75 beats per minute, BP of 125 systolic 80 diastolic, and respiratory rate of 14 breaths per minute. His physician begins anti-anginal therapy with oral diltiazem 120 mg once daily. Is this a good option for TBN and his chronic stable angina? Calcium channel blockers are effective in both vasospastic and classic exertional angina. These drugs relieve vasospasm of the large coronary arteries and, as a result, are effective in treating Prinzmetal variant angina. Their beneficial effect in chronic stable, effort-induced angina is the result of multiple factors. Their vasodilatory effects in the coronary circulation increase myocardial oxygen supply, whereas dilation of the peripheral arterioles leads to a reduction in myocardial oxygen demand. Because coronary vasospasm can occur at the site of an atherosclerotic plaque, a calcium channel blocker is particularly useful in patients who have a vasospastic component to their angina. Although beta blockers are considered the drugs of choice when instituting anti-anginal therapy, data indicate that the selection of a heart rate-lowering calcium channel blocker may also be a reasonable first-line choice. Calcium channel blockers and beta blockers appear to provide equivalent efficacy in head-to-head trials of chronic stable angina. In addition, the available head-to-head trials with sufficient numbers also suggest that calcium channel blockers and beta blockers produce similar effects on cardiovascular outcomes and mortality in patients with chronic stable angina. In addition, several trials in the setting of hypertension with coronary artery disease have demonstrated that calcium channel blockers can produce meaningful reductions in mortality. It would appear that either a heart rate-lowering calcium channel blocker, or a beta blocker, may be considered relatively equal options and initial therapy for chronic stable angina. The selection of a particular class will likely be dictated by patient characteristics. In the case of TBN, his asthma may be worsened by the addition of a beta blocker. Although a cardioselective beta blocker could be tried to see if TBN could tolerate it, a heart rate lowering calcium channel blocker is a good alternative to a beta blocker for the treatment of angina in this situation. The choice of a calcium channel blocker as initial therapy in this patient is appropriate due to TBN's previous intolerance to nitrates and because nitrate therapy requires a nitrate-free period. Given TBN's current heart rate and BP, the selection of a heart rate-lowering calcium channel blocker seems most appropriate. However, the distinct pharmacologic and adverse event profiles of the various classes may dictate agent selection from patient to patient. Some side effects of calcium channel blockers reflect an extension of their hemodynamic and electrophysiologic profiles and, therefore, are predictable. Dihydropyridine-induced hypotension and dizziness occur in approximately 15% of patients. Patients also may complain of lightheadedness, facial flushing, headache, and nausea. Swelling of the lower legs and ankles, that is peripheral edema, is related to the potent peripheral vasodilating effects of these agents. The non-dihydropyridines, verapamil and diltiazem, have similar side effect profiles, although diltiazem appears to be better tolerated. The lower incidence of side effects reported with diltiazem, compared with verapamil, may reflect a true difference or, perhaps, less aggressive dosing regimens. Both drugs can cause sinus bradycardia and worsen already existing conduction defects and heart block. Neither should be used in patients with sick sinus syndrome or advanced degrees of heart block unless a functioning ventricular pacemaker is present. Patients should be monitored for signs of worsening heart failure, such as shortness of breath, weight gain, and peripheral edema. Verapamil-induced constipation can be particularly troublesome to the elderly. Appreciation for the individual side effect profiles helps determine preference for one calcium channel blocker over another. TBN is not likely to experience major side effects with either verapamil or diltiazem. The next question reads, on questioning, TBN does not report any previous adverse events or tolerance issues with an ACE inhibitor. Is an angiotensin II receptor blocker appropriate to use in TBN, or should he be switched to an ACE inhibitor for his coronary artery disease? As discussed previously, the totality of available evidence supports the role of ACE inhibitors in reducing total mortality, cardiovascular mortality, non-fatal myocardial infarction, and stroke in patients with stable ischemic heart disease and preserved ventricular function. Although in theory angiotensin II receptor blockers should produce the same beneficial effects as ACE inhibitors in patients with atherosclerosis, there are far fewer clinical trials with angiotensin II receptor blockers. The best supporting evidence comes from the Transcend and On-Target trials, both of which suggest angiotensin II receptor blockers produce similar benefits as ACE inhibitors in preventing cardiovascular disease events. Based on these trials, it would be reasonable to continue angiotensin II receptor blocker therapy in TBN at this time given he has demonstrated the ability to tolerate the medication. It would not be unreasonable though to discuss with TBN the possibility of switching to an ACE inhibitor given the substantial body of evidence that exists for patients with coronary artery disease. The combination of an ACE inhibitor and angiotensin II receptor blocker does not offer any increased benefit but does increase the risk of hyperkalemia and renal insufficiency. The next question reads, 6 months later, TBN returns to see his physician. His current therapy consists of sublingual nitroglycerin 0.4 mg tablets, losartan 100 mg once daily, fluticasone inhaler 2 puffs twice daily, albuterol inhaler 2 puffs as needed, aspirin 81 mg daily, atorvastatin 20 mg daily, and diltiazem 180 mg once daily. Current vitals include a resting heart rate of 55 beats per minute, BP of 115 systolic 65 diastolic, and respiratory rate of 10 breaths per minute. TBN states he still is having roughly 3 to 4 anginal attacks per week when he exerts himself doing yard work. Would ranolazine be a therapeutic option for his chronic stable angina at this time? Although higher doses of diltiazem might be attempted in TBN, his current heart rate and BP would likely prevent further titrating of therapy. Beta blocker therapy is not a good option due to the potential reduction in heart rate and asthma. Thus, ranolazine represents a good option for TBN at this time due to the absence of heart rate and BP lowering effects with ranolazine. Several large, randomized studies with ranolazine have been conducted, all demonstrating its effectiveness at reducing ischemia and angina when added to existing therapy. The monotherapy assessment of ranolazine in stable angina, abbreviated as MARISA, trial randomly assigned patients in a crossover fashion who had met screening criteria to either escalating doses of ranolazine 500 mg twice daily, 1000 mg twice daily, 1500 mg twice daily, or placebo. All other anti-anginal agents, except for sublingual nitroglycerin, were discontinued. Ranolazine significantly increased exercise duration, time to onset of angina, and 1 mmSt segment depression during exercise treadmill testing. Similar results were seen in the combination assessment of ranolazine in stable angina, abbreviated as CARISA trial, in which ranolazine 500 mg twice daily, 750 mg twice daily, 1000 mg twice daily was added to anti-anginal monotherapy that consisted of atenolol, diltiazem, or amlodipine. The efficacy of ranolazine in chronic angina, abbreviated as ERICA trial, assessed the effects of ranolazine added to amlodipine 10 mg per day. Up to one-half of the patients enrolled in ERICA were also on a long-acting nitrate. Patients were randomly assigned to either placebo or ranolazine 500 mg per day for 1 week and then to 1000 mg per day for an additional 6 weeks. Patients receiving 1000 mg per day of ranolazine had a significant reduction in both the number of weekly anginal attacks, as well as the number of sublingual nitroglycerin tablets used. A reduction in the frequency of angina was also seen in patients with coronary artery disease and diabetes mellitus when ranolazine was added in the type 2 diabetes evaluation of ranolazine in subjects with chronic stable angina, abbreviated as TERISA study. Ranolazine was well tolerated in all 4 of these trials, with the most common side effects being dizziness, constipation, nausea, and headache. The incidence of adverse effects increased with increasing doses. No other significant adverse effects were noted, although it is important to note that the duration of these trials was limited. Information regarding the safety of ranolazine in patients with longer drug exposure came from the ranolazine open-label experience, abbreviated as ROLL program, which followed patients from the MARISA and CARISA trials who continued in an open-label extension program. A total of 746 patients initially entered the 6-year run-on safety program. At the time of publication, the mean duration of therapy was 2.82 years, with 23.3% of patients discontinuing therapy. 1/2 of the withdrawals were because of adverse events, but the incidence of common adverse effects did not seem to change from that seen in the randomized portions of the clinical trials. Mortality rates at both 1 year, that is 2.8%, and 2 years, that is 5.6%, indicate no adverse risk of ranolazine on overall mortality. The metabolic efficiency with ranolazine for less ischemia in non-ST elevation acute coronary syndrome, abbreviated as MERLIN, TIMI 36 trial randomly assigned patients to ranolazine or placebo in the setting of acute coronary syndrome. Ranolazine was administered as an intravenous IV infusion for 12 to 96 hours, then converted to 1000 mg twice daily. Patients were assessed for clinical endpoints during the acute hospitalization, then every 4 months thereafter. The incidence of recurrent ischemia was significantly reduced, with ranolazine providing additional support for the efficacy of ranolazine in treating chronic stable angina. Although ranolazine appeared to offer no benefit in the setting of acute coronary syndrome, significant long-term safety data were seen in the trial. Importantly, the risk of mortality, sudden cardiac death, or symptomatic arrhythmias was not increased with ranolazine versus placebo. In fact, the incidence of arrhythmias in the first 7 days, as documented by Holter monitor, was significantly lower with ranolazine than with placebo. This was an important finding given ranolazine produces a dose-dependent increase in the QT interval. As QT prolongation activity has been associated with proarrhythmia in other medications, results from the MERLIN trial are reassuring that ranolazine appears to be safe to use for chronic treatment of patients with stable angina. TBN is at goal heart rate, and his BP is well controlled on his current regimen, but he continues to have anginal symptoms. Given the demonstrated efficacy in relieving anginal symptoms, as well as the safety profile in a patient like TBN, ranolazine would be an excellent option for him for additional angina control. The next question reads, how should ranolazine be dosed in TBN? Ranolazine is marketed as an extended-release tablet formulation that should be dosed twice daily. Maximal plasma concentrations are observed 4 to 6 hours after administration of the extended-release formulation with a terminal half-life of 7 hours. With twice-daily dosing of the extended-release preparation, a more favorable peak-to-trough fluctuation of 1.6 is observed. Steady state is typically reached within 3 days and oral bioavailability is 30% to 55%. Ranolazine is primarily metabolized by the liver through CYP3A4, that is 70% to 85%, and CYP2D6, that is 10% to 15%. Ranolazine also is a substrate for P-glycoprotein. Patients should initially be started at an oral dose of 500 mg twice daily, which can be titrated up to a maximal dose of 1000 mg twice daily. Although ranolazine is an option in the treatment of chronic stable angina, careful patient selection is required for the drug to be used safely and effectively. For TBN, the main issue is the drug-drug interaction with diltiazem, and the maximum dose of ranolazine that should be used in patients receiving diltiazem is 500 mg twice daily. TBN should be monitored closely for possible increased adverse effects with ranolazine. The next question reads, EHR is a 58-year-old woman with a history of chronic stable angina for the last several years that has been managed primarily with medical therapy. Her current medications include oral isosorbide mononitrate 120 mg daily, oral metoprolol succinate 200 mg daily, ranolazine 1000 mg twice daily, fluticasone 2 puffs twice daily, albuterol 2 puffs as needed, nitroglycerin spray 0.4 mg as needed for chest pain, and enteric-coated aspirin 81 mg per day. Today she returns to your pharmacy to obtain refills of her medications with her 64-year-old brother who wants to know if he should be taking an aspirin a day to prevent heart disease. His only medical history consists of hypertension for which he is taking oral hydrochlorothiazide 25 mg every day. Is primary prevention of coronary artery disease with aspirin appropriate for EHR's brother? The question of whether aspirin is valuable in the primary prevention of cardiovascular events has been debated for more than 20 years. The absolute risk-benefit ratio for aspirin in primary prevention will depend on the overall absolute risk of vascular ischemic events. Several meta-analyses suggest that any benefit for aspirin in reducing ischemic events is offset by an increase in bleeding, resulting in no net clinical benefit. In 2009, the U.S. Preventative Services Task Force developed updated guidelines for aspirin use in primary prevention, incorporating at the time of the most recent published evidence. Recommendations are differentiated initially by age and sex, recognizing that the ischemic benefit varies between men, reduction in non-fatal myocardial infarction, and women, reduction in ischemic stroke. Aspirin for primary prevention may be considered for men aged 45 to 79 years, and in women aged 55 to 78 years. Because EHR's brother is 64 years of age, it is appropriate for him to consider the use of aspirin for primary prevention. The first step is to calculate what his risk is for developing cardiovascular disease. This can be done by using a validated risk assessment scoring system, such as the Framingham Risk Score. Based on his age, if his 10-year risk of cardiovascular disease is greater than 9%, the cardiovascular disease benefit with aspirin will outweigh any potential bleeding harm according to the U.S. Preventative Service Guidelines. Recognizing the existing controversy surrounding the use of aspirin for primary prevention, a thorough review of the potential risk and benefits should take place with EHR's brother so that he may make the most informed decision possible. The next question reads, EHR also buys a bottle of over-the-counter ibuprofen. On further questioning, you learn that EHR suffers from occasional back and knee pain and uses ibuprofen 3 to 5 times a week for pain relief. How should EHR be educated regarding the use of ibuprofen and aspirin concomitantly? In 2006, the FDA released a warning statement on the concomitant use of both aspirin and ibuprofen. The impetus for the statement was the growing recognition that nonsteroidal anti-inflammatory drugs NSAIDs, in particular ibuprofen, may attenuate the antiplatelet effects of low-dose aspirin. This FDA warning was then followed by an updated scientific statement from the AHA. The mechanism of this interaction is that both aspirin and non-selective NSAIDs bind to the same acetylation sites of the cyclooxygenase enzyme. Although aspirin does this in a non-reversible fashion, binding by an NSAID occurs in a reversible fashion. If an NSAID, such as ibuprofen, is present, aspirin will be unable to bind to its site of action, and will be rapidly cleared from the plasma. The result is the patient will not receive the antiplatelet benefit of aspirin. EHR should be counseled on the consequences of the interaction between her aspirin and ibuprofen. Additionally, if she can avoid or at least minimize both dose and duration, the use of ibuprofen, the effect on her cardiovascular health would be optimized. If occasional use of ibuprofen cannot be avoided, it should be administered to minimize the potential for interacting with her aspirin. This would include taking ibuprofen at least 2 hours after her daily dose of aspirin, as well as taking her daily aspirin dose at least 8 hours after the last dose of ibuprofen. Although similar concerns exist for other non-selective NSAIDs, e.g. naproxen, and diclofenac, no formal recommendations exist on how to manage concomitant use of these agents with aspirin. Beyond the potential drug-drug interaction with aspirin therapy, there has emerged a large body of observational evidence that the use of NSAIDs in patients with underlying cardiovascular disease may increase the risk of major adverse cardiovascular events. Although the underlying mechanisms remain to be determined, clinicians should minimize the use of NSAIDs if possible in patients with underlying cardiovascular disease. The next question reads, 9 months later, EHR returns to her cardiologist stating that her chronic angina has been worsening. She is experiencing chest pain more frequently and much sooner when she does any type of physical activity. Her current medications are the same as discussed previously, and it is felt that her medical management has been optimized as much as possible. After discussions with her cardiologist, she elects to undergo revascularization with percutaneous coronary intervention for symptom relief. What is the current standard for prevention of acute complications during percutaneous coronary intervention? Percutaneous coronary intervention, also known as angioplasty, involves the percutaneous insertion of a balloon catheter into the femoral or brachial artery. The catheter is advanced up the aorta and into the coronary arteries at the coronary sinus. Percutaneous coronary intervention initially involved the inflation of a catheter-borne balloon that mechanically dilated a coronary artery obstruction through arterial intimal disruption, plaque fissuring, and stretching of the arterial wall. Balloon inflations were repeated until the plaque was compressed and coronary blood flow resumed. Since then, alternative devices have been developed, including rotational blades designed to remove atheromatous material, lasers to ablate plaques, and intracoronary stents that are designed to maintain the patency of the vessel after it is reopened. Stents can be of the bare metal, abbreviated as BMS, variety, or contain a drug impregnated on the surface of the stent to prevent restenosis, that is, drug-eluting stents. It is estimated that more than 1,265,000 percutaneous coronary intervention procedures are performed in the United States each year. An overwhelming majority of these procedures involve placement of a bare metal stent or drug-eluting stent. Percutaneous coronary intervention is indicated in patients with single-vessel or multi-vessel disease and who are either symptomatic or asymptomatic. Because of mechanical disruption of the atherosclerotic plaques and exposure of plaque contents to the bloodstream during percutaneous coronary intervention, potent antiplatelet and antithrombotic strategies are needed to prevent acute thrombotic events such as myocardial infarction and death. Current strategies in patients undergoing elective percutaneous coronary intervention involve the administration of aspirin, AP2Y12 antagonist, such as clopidogrel, prasugrel, or ticagrelor, an antithrombin agent, and occasionally a glycoprotein 2B3A receptor antagonist in selected patients. Although ticagrelor and prasugrel represent alternatives to clopidogrel in patients undergoing percutaneous coronary intervention, current ACC/AHA guidelines recommend their use only in patients undergoing percutaneous coronary intervention in the setting of acute coronary syndrome. In patients not taking aspirin on a daily basis, 300 to 325 mg of aspirin should be given at least 2 hours before the procedure. Patients currently on daily aspirin therapy should receive 75 to 325 mg of aspirin before percutaneous coronary intervention is performed. A 600 mg loading dose of clopidogrel on or before the time of the procedure is currently recommended, producing an antiplatelet action within 2 hours. Adequate antithrombin therapy such as unfractionated heparin, the low molecular weight heparin enoxaparin, or the direct thrombin inhibitor bivalirudine should be used in patients having elective percutaneous coronary intervention. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 306.